This is your first weekend as an intern and you are on backup schedule on a Saturday. And guess what? Your phone rings. And guess who's on the other side of the line? It's your favorite senior resident. He calls you up and he tells you, unfortunately, somebody called in sick, so you have to come into work. You come into work and your senior resident gives you your first case for the day. And it goes like this. A 50-year-old male with a past medical history of hyperlipidemia, coronary artery disease, presents with a sudden onset of shortness of breath. The shortness of breath was not associated with any chest pain, palpitations, or syncope. He was recently involved in a sports injury and sustained a tibial fracture for which he underwent surgery. And he has been bedridden for the past 6 weeks. His wife called EMS and is brought into the hospital. Alright everybody, so based on the history, you guys already had a very high suspicion for pulmonary embolism. However, you already know that physical examination is a very key component of any case. So let's go look at this patient's physical examination. Alright, so if you look at this patient's blood pressure on vital signs, you see a 80/55. So this is very important. Mark this one down, alright? 80/55. Heart rate of 110. And the patient got a respiratory rate of 35, which is very high, and the patient got a temperature of 100.8 degrees Fahrenheit. So this is technically fever greater than 100.4. Alright, now general examination, you see that this patient is breathing fast. He looks like he's in respiratory distress. He's breathing heavily. Alright, now when you go into your respiratory system on physical examination of the lungs, you hear bilateral equal breath sounds. There's no wheezing, there's no crackles. Everything sounds clear, but the guy is short of breath. Everything's clear on the lungs, but he's short of breath. This is a very important clue for you to remember. Alright, next is cardiovascular exam, where you got an S1, S2's heard. There's no rubs, no gallops, no murmurs. So cardiovascular system is also perfectly fine. And if you go to the lower extremity, you see the guy has a right leg which is in a cast. Alright, this is basically telling you the patient had a fracture for which is wearing a cast for the past 6 weeks. Alright guys, so based on this physical examination, I want you to connect the two. Now you have a physical examination that you're adding to your initial suspicion from this patient's case, which was pulmonary embolism. So you have pulmonary embolism. I want you to see this as a spectrum. It can go from very mild to very severe. Now this patient is in the severe because as you see, the patient's got a very low blood pressure, 80/55. What does this technically tell you? This patient is in shock. How do you define shock? Is a systolic blood pressure less than 90, or a mean arterial blood pressure less than 65, or a drop in a systolic blood pressure by more than 40 millimeters of mercury. And if all of this lasts more than 15 minutes in the context of a suspected PE, you are thinking of what? What would you call this PE? Is it a benign PE or is it something more severe? It is more severe because the patient is clearly in shock. If the patient is in shock and suspected PE, you call this a massive PE. So the guy's got a massive PE. Oh my god, you got called in on a Saturday and look at the admission that you've just received. This is an important case because this patient can crash and die anytime. So you have a patient who's hypotensive on the context of a suspected pulmonary embolism. So here we are going to call this as a massive pulmonary embolism. So let's dive right into our labs and orders and assessment and plan, because this patient is very critical. So you're going to do everything concurrently. So now we are dealing with the case of massive pulmonary embolism suspicion. Alright, you haven't proven anything yet. You are highly suspecting the patient's got a massive pulmonary embolism. Alright, so you want to go into the labs and orders, but again, remember, this patient's got a low blood pressure. You're kind of going to do everything in a hand-to-hand fashion. Alright, you're going to place your labs and orders. So let's just talk about the labs and orders that you are going to place in this patient. So we'll get our regular labs. You want to get your CBC. Alright, you want to see what the patient's hemoglobin is. You want to see what the patient's platelet count is, right? So you want to know what the hemoglobin is. You want to know what the platelet count is. Maybe you want to know what the WBC count is as well, because the patient did have a fever, right? All right. Next, you want to see the CMP because you're looking at the creatinine levels. You want to look at potassium. You want to look at magnesium as well as the rest of the complete metabolic panel as well. All right, PT, PTT, INR. Now this becomes a very important component of this patient's labs and orders. All right, so you want to get the patient's coagulation profile, and then you want to get a troponin level and a BNP level. I'm going to put a box around these two tests. All right, troponin and a BNP level. It's very important for you to get in this patient's case. And also I want you to get an ABG. Remember, the patient is having respiratory distress. All right, apart from the ABG, you must have also get a oxygen saturation. So you want to get a pulse oximetry on this patient, and in this patient, in fact, you will see that the patient is hypoxic on room air. So you want to give the patient some amount of oxygen via nasal cannula, face mask, or a non-rebreather, but the patient is hypoxic on pulse oximetry. If the patient is hypoxic on pulse oximetry, next step, you must get a arterial blood gas. And in the arterial blood gas, I want you to calculate something known as the AA gradient. All right, AA gradient, basically telling you how much of oxygen there comes into the alveolus and the amount of oxygen that's present in the blood. You want to compare the two. If there's a discrepancy, that means the patient has an elevated AA gradient. The normal AA gradient is about 5 to 10. All right, so that's the normal AA gradient. Now, how you calculate the AA gradient is covered in one of the shorter clips that we have on the channel, so watch that and learn that. However, you must calculate an AA gradient in this patient by getting a arterial blood gas, and then you must also get an EKG. All right, so EKG is important because the patient has had coronary artery disease before. This might as well be an acute MI, so you must get an EKG to make sure there is no ST segment elevation MI in this patient. However, when you do an EKG, right, and you're suspecting a patient has pulmonary embolism, the most common finding that you would find is what? Is it the S1, Q3, T3 pattern? Absolutely not. It's not. The most common finding is in fact just sinus tachycardia. All right. So most common finding you will find is in fact going to be a sinus tachycardia. Okay. I'm just going to put ST for sinus tachycardia. Number two, you'll have non-specific ST or T wave changes, just non-specific changes. Or the big one which we normally get is going to be S1, Q3, T3, and it looks like this. So you've got your labs and you've done your EKG. So again, important thing is, as I said, this patient has got a massive pulmonary embolism. So you want to get your basic lab work here. But let's go to the impression. Assessment plan tells you, a senior resident, and you're attending, that you know what you're talking about. So your assessment plan is in fact going to be a massive pulmonary embolism, a massive PE. This is the highest it could get. As I've already told you, you're dealing with a patient with a massive pulmonary embolism, right? You need to work simultaneously. You need your labs and orders being done, but the patient is clearly hypotensive. So let's dive right into the assessment and plan as well. We're not done with the labs and orders, but I want to do it concurrently, all right? So you're suspecting this patient's got what? What is your assessment and plan? The patient has a shortness of breath, most likely secondary to a massive pulmonary embolism. It's a massive PE. All right, now when you're thinking of assessment and plan, there's two parts to the story. Number one is you need to prove that this patient has pulmonary embolism. Number two is that you need to treat it. Are you going to do which one first? You need to, that's the big decision that you have to make. Again, sometimes you can go with one, sometimes you can go with the other. Important thing is your clinical judgment and practice like a clinician. You need to know what to do first, all right? So this patient, massive PE, let's put it has important lab tests that you're going to do, and the other one is going to be treatment, all right? Treatment. So let me go into treatment first. So clearly the patient is hypotensive. We cannot let this person be hypotensive for too long. So the patient is hypotensive. What are you going to give this patient? You want to give this guy fluid, right? You want to give him fluid. So we are going to put fluids. Now your choice of fluids normally is going to be either normal saline or Ringer's lactate. Either one is fine, all right? Normal saline or Ringer's lactate for volume expansion. Now if somebody asks you what type of shock is pulmonary embolism, it is a type of obstructive shock, right? It's an obstructive shock. If I drew the heart just really quick here, right? If this is the heart and this is your right ventricle, and you guys know the right ventricle is supplying your pulmonary arteries, it's gonna have your lungs, right? This is how the blood supply goes. And now I'm telling you, there's a patient has a massive PE, meaning he's got a large clot sitting in here on the pulmonary artery. All right, so the patient's got a massive PE. All right, now my other question is, you're going to give this guy fluids. Now one more thing, just to take a step back, I want you to know that if a patient has a massive pulmonary embolism, what's going to happen to your right ventricle? Is the pressure going to go up? Yes, it is, right? Because there's a lot of pressure here. The pressure is going to go up. Your right ventricle is straining, right? It's straining. It's going to have some dilation. It's going to have some hypokinesis, right? Your right ventricle is going to look so dilated. So that is an important finding that you're going to see in a patient with massive pulmonary embolism. So I want you to remember this. Reason is, if you're going to give the patient fluid, now you're telling me if I give fluid, obviously you're giving it to the venous drainage, isn't it? You give fluid to the venous system, which wherever you give it, it could be through SVC, IVC. Eventually your SVC and IVC are going to be coming to your right atrium, right? Right atrium. So if I give a lot of fluid, the fluid's going to come here, accumulate in your right ventricle, and the fluid cannot go. Oh wow, wait a second, the fluid cannot go, right? It's an obstructive type of shock, and now you're giving a ton of fluid to this patient, and this is going to cause more strain in your right ventricle. It's going to cause more dilation. This is going to compromise on the blood flow to the ventricle. You can cause an acute right ventricular infarction of your heart. So this is an important concept, so which means you must give fluid. However, you have to be cautious. The ideal method to use, you could give them about 500 ml or 1000 ml in short boluses. All right, that's what you're going to do. You're going to give fluids, but again, you're not going to give like 5 liters at once. The reason is you want to be cautious because this could cause worsening of the patient's presentation. Fine, you got your fluids in. Now you gave the fluid and the blood pressure is not going up. What are you going to do next? Well, obviously you're going to ask your senior what to do, and your senior is going to say, well, start the patient on pressors. Oh, very good. Thanks a lot for that, right? Pressors. Which pressors? There are like 6 pressors out there. So the choice of pressor, what are you going to pick? Number 1 that you will pick is in fact going to be norepinephrine. Norepinephrine is a very good pressor that we use for pretty much any and every type of shock. So norepinephrine would have been a great guess to go with, and norepinephrine works beautifully. All right, so norepinephrine will be your first choice to start in a patient with massive pulmonary embolism. What about choice number 2? Choice number 2 is gonna be dobutamine. Now if you guys recall what dobutamine is in fact a inotropic agent. It causes beta 1 stimulation of your heart, and this is gonna cause contraction, right? Increase inotropy, and that's gonna cause more fluid to get out of the heart. So dobutamine is a good drug. However, if you recall, is there a beta 2 receptor in your blood vessels in the peripheral system? Yes, there is. What happens if you stimulate your beta 2 receptors? You would cause vasodilation. So a side effect of dobutamine is in fact causing vasodilation and can cause hypotension. So what they normally recommend is you want to start norepinephrine and add on dobutamine to it. Either way, I want you to remember 2 important pressors that you will use is norepinephrine followed by dobutamine. So you're done with giving fluids and pressor support for this patient. So your next big question really is, are you going to treat this patient? Are you going to treat this patient with anticoagulation? The decision making of anticoagulation does not seem so hard. Important thing what you need to know is the patient having any contraindication for anticoagulation? It's that straightforward. You want to see, okay, does this guy has a risk factor that I should not give him any anticoagulation? The way you're going to assess it is by memorizing this table. So you guys can go over this table and remember what the absolute and relative contraindications to anticoagulations are. Or you could follow this other scoring system that's present called Hasbled score. The Hasbled score is used in the context of DVTs, pulmonary embolism, also in atrial fibrillation. It's just a rough method to analyze and see what the risk of the patient's bleeding is. So based on this, you can actually assess and say, does the patient have a low risk of bleeding, a moderate risk of bleeding, or a high risk of bleeding? So it's very straightforward. The way you're going to decide is if the patient's got a bleeding risk or not. So what I'm going to do is, if the patient has, I'm going to put as low bleeding risk, a moderate bleeding risk, and a high bleeding risk, right? So let's take care of the low bleeding risk person. If you obviously know the patient has zero bleeding risk, at this point what are you going to do? You can start the patient on heparin. Now the thing is this, with regards to what kind of anticoagulation you want to give, you actually in the hospital you have multiple choices, all right? If the patient is inpatient, you have two choices more or less, which is going to be a lower molecular weight heparin, which is Lovenox, or you could use heparin. The reason I'm choosing heparin here is heparin has a very short half-life, and therefore because I am going to do one step further in this hemodynamically unstable patient, so I want to use a drug that's going to be shorter lasting. Therefore if I can stop it, I can be able to give the other medication faster. So heparin is going to be my first choice in this patient. Now the dosing that you actually give for a patient as a loading dose for heparin is going to be 80 units per kilogram of body weight, all right, followed by 18 units per kilogram of body weight per hour. This is how your initial dosing of heparin is going to be, and it's going to be a heparin drip. And what you're going to be following is a PTT level. How often are you going to be following this? You're going to follow it every 6 hourly. And what is your target? A lot of people say 45 to 70, 45 to 60. No, what you're going to do is 1.5 times to 2.5 times patient's baseline. All right, whatever the patient's baseline is, you want to fall between 1.5 to 2.5 of the patient's baseline, because the baseline of the PTT could vary from patient to patient. That's why I don't want to set target between 40 to 70. Go based on 1.5 to 2.5 times the patient's baseline. All right, so you started the patient on a heparin drip, all and fine, but is this the treatment for breaking down a clot because the patient's got a massive pulmonary embolism? No, it isn't, right? However, you're not going to waste time. You must get a confirmatory test to figure out if you can give thrombolysis. You're not going to give thrombolysis to a patient who you have not confirmed who has a pulmonary embolism. Without a confirmatory test, you cannot give TPA. So the question is, how are you going to confirm this patient has a PE? So the patient's got a heparin drip running. Good, you're basically giving the patient anticoagulation, all and well. So your next step really becomes, how are you going to identify if the patient's got a pulmonary embolism? You have three options. The best choice is in fact going to be a CT angiography, or you could do a VQ scan, or you could do something else. I'll come to this something else in just a second. Your gold standard for diagnosis of pulmonary embolism is in fact going to be a CT angiography, where you give contrast and you see the vasculature of the lungs and you can tell exactly where the clot is, which is perfect. And it's also very good for central pulmonary embolism. It's very bad for the peripheral small clots that get shot into the lungs. However, VQ scan, which is a ventilation perfusion scan, again, it's most of the time it's preferred if the patient's got renal insufficiency, because CT angiography, you are giving contrast and there could be nephropathy from it. So in patients with renal insufficiency, we actually prefer a VQ scan. Alright, so the thing is, with this patient, as I already said, patient is hemodynamically unstable, right? You have him on pressors running. You may have even intubated this patient sometimes, right? So the patient is kind of more on the critical side. So in this case, it might be an instant where you cannot move the patient to get a CT angiography. However, if the patient was still fine, you have all these things and was safe, fine, you can go ahead and get a CT angio and you could prove the patient's got a PE. Or you could have done a VQ scan and prove that the patient's got a PE. What if you could not do both these tests? What are you going to do then? Oh my God, you're stuck now, aren't you? You cannot prove that this patient's got a pulmonary embolism. How are you going to give you a TPA? This is where your echo comes into play. You could do a bedside echocardiography, and recall what I explained before about your right ventricle. Remember what your right ventricle was going through with all that strain in your pulmonary arteries? It was causing a right ventricular dilation. It was causing right ventricular hypokinesis. Alright, and I want you guys to look up a specific sign known as McConnell sign. Alright, McConnell sign, all right, which is an imaging which is seen on echocardiography. It's a finding which is highly suggestive of pulmonary embolism. Essentially, what it shows is diffuse hypokinesis of the right ventricle. However, it does not affect your apex. It's just a cool fact, remember. It's not going to affect your management as an intern. All right, what you need to know is you can CT angiography, you could do a VQ scan. If you can do both of them, you will do an echo, and essentially what you're looking for is right heart strain. You will look for the right heart strain, and the moment the right heart strain is present, now it confirms, all right, the patient most likely got a massive pulmonary embolism. All right, so once you've confirmed it, now you got to treat it. So how are you going to treat it? I'm going to wipe out my lab test that we just did here, and what we're going to do is you are going to give this patient TPA, but the guy is on heparin, right? What are you going to do? Stop the heparin. Moment you confirmed your pulmonary embolism, stop the heparin and give the patient TPA. And once you give the patient TPA, you expect the patient to improve. All right, let's go one round and say patient improved. Very good. What are you going to do at that point? Restart the heparin. If the patient improved, TPA, restart the heparin and continue the heparin drip, monitoring your PTT. All right, very good. Now, if you gave TPA and the patient did not improve, he's still hemodynamically unstable, still requiring a lot of pressor support, what are you going to do next? Let's try TPA again. Let's give him TPA again. You can try TPA for the second time. Fine. You gave TPA and the patient still doesn't improve. Now what options do you really have? Here you have two more options. Honestly speaking, the best treatment for a person with massive pulmonary embolism is in fact a surgical removal of the clot. All right. The best treatment is in fact going to be surgical embolectomy. All right, surgical embolectomy. But if I'm talking about surgical embolectomy, all I'm saying is patient has to go for a open heart surgery, and you got to remove this clot. This is a major surgery, and not many hospitals are going to have the facility to do this in an acute setting like this patient. So in those patients, what you're going to do is catheter embolectomy. Okay, catheter embolectomy. There's multiple embolectomies that could be done, different types and whatnot, but you can't remember. Either you can go with a catheter and suck out this clot, or you can do a open heart surgery. So this is exactly how you're going to treat a patient with massive pulmonary embolism. All right, just to recap what our assessment and plan was. The patient is in shock. What are you going to do? Give the patient fluids, give the patient pressors. Next, you want to decide if you want to give the patient anticoagulation or not. How are you going to decide if you want to do anticoagulation or not? You're going to follow this table or this table. Alright, so based on these tables, you're going to decide how much risk the patient has for bleeding. If the bleeding risk is very low, at this point you're going to give the patient heparin. You're going to start the patient on a heparin drip, and your next step is to diagnose the presence of a pulmonary embolism. The gold standard test is CT angiography. The other option you have is a VQ scan. If you cannot move the patient because the patient is too unstable, what are you going to do? You're going to do a bedside echo. And what are you looking for? You're looking for a right heart strain. If that's present, all in well, you have diagnosed a presence of a PE. How are you going to treat at this point? You will give the patient TPA, but before giving TPA, stop the heparin, give TPA. If the patient improves, beautiful, you've done well. Start the patient back on heparin and move on with your life. If the patient does not improve, you try TPA again, or you could either send the patient for a surgical embolectomy or a catheter driven embolectomy. Alright guys, I really hope that you guys learned this. This is as simplified as possible that I could make it. It is a big subject, but if you know how to manage a patient in this exact manner, you should be perfectly fine for your internship. So we're done talking about a patient with low risk of bleeding. It is pretty straightforward. We already talked about how you're going to manage the patient. However, we still have to cover the patient's management when it is a very high risk of bleeding, or the patient's got a moderate risk of bleeding. High risk of bleeding is also going to be very straightforward. Patients coming with a massive PE, you know that you need to give the patient anticoagulation, but patient's got a very high bleeding risk. What are you gonna do? Clearly, you cannot give the patient heparin, you cannot give the patient Lovenox, you cannot give the patient thrombolytics. So what options do you really have? All your options that you're gonna have at this point is you want to expedite diagnosing your PE as soon as possible. So you want to try to get this test done as soon as possible. Get your CTA, you could do your VQ scan or do a bedside echocardiography and look at the right ventricular stain. Either method, you must do your test as soon as possible and diagnose the presence of PE. Once you've diagnosed it, now you have pretty much only surgical options or placement of a IVC filter. So the way you're going to go once you diagnose it is placement of an IVC filter, or the patient can go for either surgical embolectomy or a catheter driven embolectomy. That's your only option that you're gonna have for your patient. That's it. You cannot give anticoagulation. Your options are pretty straight. Either put an IVC filter or do surgical, which is gonna be surgical embolectomy or a catheter driven embolectomy. So pretty straightforward, right guys? I mean, you know how to manage a patient if the patient had a very low risk of bleeding, which is very complete. You also know how to manage a patient with a high risk of bleeding. What with moderate risk of bleeding? This is pretty controversial. You are gonna see a case by case basis. Again, you're gonna measure risk versus benefit. It's a gray area. It's gonna be a decision making. Now, important thing is I want you guys to remember how to manage, how I've already told you about a low risk patient of bleeding with a massive pulmonary embolism and a high risk of bleeding, how you're gonna manage. This is the questions that you need to know the answers to. Yeah. Alright guys, so this concludes the case of a massive pulmonary embolism. This is more of a critical patient who is not going to come to the floor, but rather the patient is going to go to the medical ICU. And as an intern, you will have to know how to manage a patient in the medical ICU who's coming with a massive pulmonary embolism, and it's such a very hot topic, you must know. Alright guys, so the important other question that you need to know answers to with regards to how long the patient is going to be on anticoagulation and what is the patient going to go home on and this and that, you will watch on the other section, which is going to be pertaining to a submassive PE and low probability PE. It's all going to be covered in that area. So make sure you watch that video as well to get a complete understanding of pulmonary embolism. Do not miss anything. Alright guys, so I hope you guys enjoyed this video. Please subscribe to our channel and hit the like button as well as the little bell button on the right hand corner so you get notifications when we make our next video. Thank you for watching and see you guys on the next video.